And so metabolism, simply put, is just sort of how our body processes the energy we bring in, mainly food and calories, how we take that energy and convert it to energy we can use in our body or store it for energy for later. So in a perfectly moving system, our energy inputs meet our energy outputs and ability to store. So then when our energy inputs, food, is lower, we can access those stores and burn for energy. So we have sort of this constant supply of energy that our body can efficiently produce, either from the food we eat or from our stored energy.
Welcome back to the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. I'm your host. My name is Dr. Scott Sherr. Our guest on today is Dr. Bret Scher. No relation, spelled differently. Dr. Bret Scher is a board-certified cardiologist, lipidologist, and leading expert in therapeutic uses of metabolic therapies, including the ketogenic diet, and is the director of Metabolic Mind, a nonprofit initiative of the Baszucki Group. Dr. Scher was most recently the medical director of dietdoctor.com before becoming the medical director and Director of Metabolic Mind. He also runs a preventative cardiology telemedicine practice at lowcarbcardiologist.com. Bret has spent most of his 20-year career as a preventative cardiologist, helping people improve their metabolic health and prevent heart disease using low-carb nutrition and lifestyle interventions. Now Dr. Scher creates educational videos and podcasts regarding the connection between metabolic and mental health and how metabolic therapies can play a key role in mental health treatment. He believes that we can revolutionize the mental health field through a great understanding of metabolic therapies and ketogenic diets. You can find his content on the Metabolic Mind YouTube page and on his podcast, metabolicmind.org. That's where you can find it. So Dr. Bret and I had a fantastic conversation. We really started off with a definition of what metabolic health really is and how truly poor metabolic health is in the United States in general. We then transitioned to speak about his nonprofit organization that he's the director of, Metabolic Mind. We spoke about the various research that's happening in metabolic health and mental health, including bipolar disease, schizophrenia, depression, and even anorexia, which is super interesting. And we had a really good time and really interesting conversation about anorexia specifically. We also discussed the actual mechanisms of action of the ketogenic diet in mental health, decreasing inflammation, mitochondrial biogenesis, et cetera. We then transitioned over to speak about understanding how the ketogenic diet affects various types of cardiology markers, cardiac markers, LDL, ApoB, and then what these markers look like in the overall context in health, and how he thinks about using statins, Zetia, and other types of therapies, but also looking at things, of course, from a lifestyle perspective first, before going the side of looking at drugs and other medical interventions when necessary. We finished up the conversation speaking about metabolic flexibility. This is a big topic, but we spoke about how it's really important to think about metabolic flexibility in the context of whether you're metabolically healthy or not, and then decide whether you want to be metabolically flexible or not. So I really hope you enjoyed this conversation with Dr. Bret Scher. We had a great time, and I look forward to hearing your thoughts. Enjoy.
Dr. Scher, it's nice to meet you.
Hey, pleasure to meet you, Dr. Scher.
I know we don't get to talk to each other like that very often, right? So different spelling, but same pronunciation, ladies and gentlemen. I'm Dr. Scott Scher. This is Dr. Bret Scher. And Bret, it's really awesome to have you on the podcast, the Smarter Not Harder podcast with us today. And the introduction from Lucia was really well timed, especially because a lot of the work that you're doing with this new group that you're working with called Metabolic Mind, which I'm excited to talk to you about. But actually, one question that I had for you that I thought would be helpful to kind of set the stage a little bit is one question I get a lot from patients and from actually my colleagues even that are not involved in the world of the ketogenic diet or metabolic therapies is what is, and this is a large question, but I think we'll get from there to a lot of more specifics, is how do we define metabolic health? Mm-hmm. We know that most people are not metabolically healthy. We talk about the ketogenic diet as being a metabolic therapy, but let's start off with the overall definition is what is metabolic health?
Yeah. So first, what is metabolism? I think before we talk about metabolic health, we have to talk about what is metabolism. So metabolism, simply put, is just sort of how our body processes the energy we bring in, mainly food and calories, how we take that energy and convert it to energy we can use in our body or store it for energy for later. So in a perfectly moving system, our energy inputs meet our energy outputs and ability to store. So then when our energy inputs, food, is lower, we can access those stores and burn for energy. So we have sort of this constant supply of energy that our body can efficiently produce, either from the food we eat or from our stored energy. Now, so metabolic health is just being able to do that well. And so metabolic dysfunction is when that goes wrong. And if you think about it from an evolutionary perspective, our metabolism is fascinating. I mean, it really is so interesting how we've evolved, that we've evolved to survive in times of food surplus, like there's a big hunt and a big kill, or a big foraging expedition, or you find a beehive or something, and we can take all that energy and protein and building blocks and use it now. But then our body says, okay, we've got enough energy, let's store the rest for later. Because our bodies are smart enough, I guess, to know that in our evolution, then there were times where we didn't have hunting success and we couldn't forage for food very well. And we could go days or a week or more, or whatever, without food. So then we said, okay, now we have these stores that we can access and use. So fast forward to now, where we're not hunting, we're not foraging, there's a 7-Eleven, a convenience store on every corner, a taco shop. I'm here in San Diego, so a taco shop on every corner, open 24 hours a day. You don't get the ebbs and flows. Instead, you get the constant supply of food. So we overwhelm this evolutionary metabolic system by just having input. So the body's like, whoa, there's constant energy. What do I do with it? Okay, store as much as we can, but then our storage just gets full. So then we have to start storing in our liver and our pancreas, and that's our visceral fat, and then that affects the function of those organs and endocrine function, and so that's sort of this process of metabolic dysfunction, going from metabolic health to metabolic dysfunction, where we can no longer adequately process the food coming in, the energy coming in, to efficiently create energy. And that ties in with insulin resistance and hyperinsulinemia, because when you have constant caloric intake, especially from carbohydrates, your insulin is constantly high. And when that happens, the cells will sort of basically stop listening to the insulin as well. You can think about it as almost like a drug tolerance. If you keep taking narcotics, your body gets a tolerance to it. Well, the cells kind of get a tolerance to the insulin. So now take more and more insulin to achieve the same effect. So the hyperinsulinemia is sort of like a marker for this metabolic dysfunction. So I don't know, that was a little long-winded, but hopefully it sort of ties together metabolism, metabolic health, and metabolic dysfunction, and this societal to evolutionary mismatch that we're in right now.
Yeah, that's beautifully said. And I think the last statistics are maybe about what's the percentage of U.S. adults that are actually metabolic healthy? Do we have a sense of that?
There was one report, I think, that said 12% were metabolically healthy, and then a new one after that came out and said 7% were metabolically healthy. So we're not going in the right direction. Yeah. And I guess the other way is the way you can define it. I mean, traditionally, it's in medicine, it's the metabolic syndrome, which is if you have a high waist circumference, you have high blood pressure, high triglycerides, low HDL. But by the time you get to metabolic syndrome, I mean, the cat's out of the bag, and it's weight related. We got to address it much earlier. So those are the traditional markers, but you can use fasting insulin levels. You can use a glucose triglyceride index. You could just use triglyceride to HDL ratio. There are other markers you can use, but they're all basically markers of poor metabolism.
Right. I think that's perfectly said, because what I will typically get back from you when I say metabolic health, people ask me about metabolic syndrome.
Yeah.
Because they've heard of metabolic syndrome, but that, as you mentioned very appropriately, is sort of not an end stage, but that is significantly along the road of metabolic dysfunction when you're having those markers and you're having those things like your waist circumference go up and your blood pressure go up and the hyperinsulinemia, et cetera. There are earlier signs of these things that we can find. And one of the things we do at our nonprofit organization is train doctors on how to actually interpret metabolomic testing. And metabolomic testing is looking at your metabolism in real time and seeing how well are you processing your macronutrients, your vitamins, minerals, and nutrients, how well are you making energy, how poorly are you making energy from all different types of energy sources, from your glucose metabolism, from fat oxidation, et cetera. So there are ways to measure these things prior to these things manifesting as various types of symptoms or syndromes. Everything from metabolic syndrome to mental health problems, which is really interesting in the work that you're doing, Bret. And that's kind of where I want to go now, which is I know that you're a trained cardiologist and that you still have a cardiology practice. And I think that's awesome. And I definitely want to get into that maybe at the end if we have time. But I think where my interest personally is, I'm in the world of hyperbaric oxygen therapy. I've been involved in that world for many years. And I do a lot of work with brain injury. I do a lot of work with mental health, a lot of PTSD, and I've had a lot of great success. But I've often found that if you're not doing the basic stuff first, you're not going to see the results that you want. And this is a general principle for almost everything. It's in the world of the ketogenic diet. It's like you just go to keto pizza and keto cookies. You're not following the ketogenic diet. You're just having keto pizza and keto cookies. It's the same thing of going into a hyperbaric chamber. It's the same deal. So I'd love to hear about how you transitioned from being a cardiologist to being the medical director or one of the main principals in this company called Metabolic Mind. And tell us a little bit about what Metabolic Mind is.
Yeah, I'd be happy to. Thanks for asking. So my journey, briefly, I was a cardiologist focusing on prevention, but general cardiology. But through that, became more interested in metabolic health and cardiometabolic health, and how our metabolism, our metabolic dysfunction impacted our risk and presentation of cardiovascular disease. And from there, really got into ketogenic nutrition, ketogenic therapy as a metabolic therapy. I was a medical director at dietdoctor.com, where we really focused on this evidence-based approach of ketogenic therapies for improving metabolic health, type 2 diabetes, and so forth. So really became just very deeply involved in ketogenic therapies. And that's where I was fortunate enough to meet the Baszuckis and what they were starting with Metabolic Mind. And at first, when I heard what they were doing, my first reaction was, I'm well connected in this field. I can totally find somebody to help you run this because I'm a cardiologist, but I can find the right person for you. And then as we got to know each other and I got to learn what they were doing, I realized what they really need is somebody who is an expert in metabolic health, someone who's an expert in ketogenic therapies, and can help communicate this to the general public and clinicians. And all of a sudden I thought, well, maybe that is me. And to have this opportunity to really be on the forefront of transforming an entire field of medicine just seemed like such an amazing opportunity to help so many people in a way that they aren't being helped right now. You look at the statistics of mental illness and you look at the statistics of how impactful it is for young people's lives, and the increased risk of death is dramatic. And you hear Jan's story and her and her husband Dave and their son Matt and what they went through, how their lives were just upended when he was really struggling to find treatment for bipolar disorder and was homeless and living behind the dumpster. And these stories can end, and frequently do end tragically, but fortunately for them it didn't. And they said, we want to make sure nobody else goes through this. We want to do whatever we can to give people the information they need so that they can find adequate treatment. And you look at what treatment for psychiatric disorders are now. And it's like a lot of chronic diseases in medicine. For the acute phase, it's pretty good. Helping someone who's acutely suicidal or psychotic or manic, it's pretty good at helping that person. But chronic treatment to help them live well and thrive is really just substandard. It's really not achieving what we should be achieving. And if ketogenic therapies and metabolic therapies are one more piece of the puzzle to help people do that, wow, we can transform a lot of lives. So once I sort of put all that together, I said, this is the place for me. And I've been there about 7 months now, and we really are doing our best to educate people about this connection between metabolic health and mental health, because those who have serious mental illness are much more likely to have metabolic dysfunction, and people with metabolic dysfunction are more likely to develop depression or even bipolar disorder, schizophrenia, anxiety. It's all related. And now even anorexia is on the scene as something that we can really potentially treat well with ketogenic therapy. So we're trying to put that information out there. At the same time, funding research, because it's one thing to go off of anecdotal reports and clinical experience and some observations, but to actually fund the research. Because it's interesting when you think about what level of evidence do we need to supply for people to say that this is something they should try. And there's different level of evidence if you're living with mental illness, or a family member of someone living with mental illness, or if you're a practicing physician, or if you're writing guidelines, right? So clearly, if you are struggling to find a treatment that works for you and it's just completely decimating your quality of life, you'll try just about anything, right? So the level of evidence for that person is a little bit lower. But we also want to reach the practicing physicians, and that's where we really need to get the research to get into the hands of the practicing physicians, and then eventually to write the guidelines. So this is, how you transform a field of medicine for the better, which is exactly what we're trying to do. You start with the case reports, you start with the personal experience, you go to the clinical experience, you back it up with research, and you provide the education to let the individual and the practitioners know what this is, how you can safely and effectively do it, and how you can improve the lives of your patients.
Yeah, beautifully said. I think one of the things that I think would be helpful to start off with in this case is let's talk about what evidence that we do have that metabolic therapies like the ketogenic diet can be helpful in mental illness as a whole. I mean, I know where this starts, which is a long time ago with epilepsy. But let's give us that story and talk a little bit about that.
Yeah. So what's interesting, I think a good way to think about it is, how do ketogenic therapies help the brain? Right? Because the brain is one big, one organ that doesn't have a mental health side and a seizure side and a dementia side, right? It's a brain, and different disease processes can manifest in the brain, but it's basically the brain. So it goes back over 100 years where doctors realized that kids who had epilepsy and seizures and were not well controlled, when they fasted, their seizures would improve. But you can't fast somebody long term.
Sure.
So they wanted to try a diet that sort of mimicked fasting, and it was a very high fat, very low carb, low protein ketogenic diet. So that was 100 years ago. So fast forward to now, we've got numerous randomized controlled trials and meta-analysis and Cochrane reviews demonstrating that ketogenic therapies work for controlling seizures. So it's not just clinical experience. It is decades of research plus clinical experience demonstrating that ketogenic therapies work for helping kids with epilepsy control their seizures.
And safety too, and significant safety as well.
I'm sorry, say that again?
Significant safety as well.
Safety as well. Now, what's interesting is there are a number of reports of stunted growth and what they call sort of malnutrition based on nutrients, but it depends on when you're treating. Because if you're treating 2 and 3 year olds, but they all catch up, their growth catches up. So if you're going to trade a little bit of growth as a 3 or 4 year old to control your seizures, when you're going to catch up eventually, that seems like a good trade. But here's the other point: the ketogenic therapy for epilepsy started off as what's called 4-to-1 therapy, meaning the fat ratio to the protein and carb ratio is 4-to-1, which is huge. It's very high fat, low protein. It's not a long-term sustainable diet, meaning years and years and years because of the low protein. But it's not meant to be. But now we have studies, in large part thanks to Dr. Eric Kossoff and his crew, looking at a modified Atkins diet, which is a ketogenic diet. It's just called modified Atkins because you don't restrict the protein in the same ratio. You say you limit your carbs, you get your 20, 25, 30% of protein, and the rest is fat. It's more loose like that. And that also impacts seizure frequency and benefits seizure frequency. So it's clear ketogenic therapies help the brain. So now, okay, you're talking about seizures. Well, what does this have to do with mental illness? Well, the hypothesis of how it affects the brain is by giving the brain ketones, you reduce neuroinflammation, you can balance neurotransmitters. GABA goes up, glutamate goes down. You can improve mitochondrial health and mitochondrial function in the brain, which has to do with energy production. And as we start talking about metabolic dysfunction, if you do have brain insulin resistance, all of a sudden the ketones are being used for fuel, bypassing the need for insulin and insulin sensitivity for the most part.
So just a quick question.
Sorry, go ahead.
That's okay. Quick question on some of the mechanisms, because I think this is helpful.
Yeah.
I completely agree that, this is exactly, the brain is just the rest of the body. Like, all we're talking about here is that cells have to work, whether they're in the brain or they're in your toe, and they have to have the right levels of optimized levels of vitamins, minerals, and nutrients. And if they're inflamed, they're not going to work. If they're toxic, they're not going to work. So how do we know some of these mechanisms? And I think just kind of breaking it down, what is the mechanism of how the ketogenic diet decreases inflammation overall? Do we know?
Well, there has been research looking at the NRLP3 inflammasome. That ketones can reduce that, and that's a major inflammatory marker. So ketones can reduce that. So something about the ketones can directly influence this one pathway of inflammation and reduce it. I'm sure there are probably other mechanisms that people are studying that I'm not aware of, but yeah.
Is it also through like how it optimizes mitochondrial function in the sense of?
Yeah, certainly could be, right?
Yeah, in the sense of if you're having the ability to optimize mitochondrial function, because we know the ketogenic diet increases mitochondrial biogenesis. We all know so you're making new mitochondria. So when you're making new ones, you're making more efficient ones. We also talk about how ketones are more clean burning fuel overall. And what is the reason behind that? Why do we say that overall?
Well, it's more efficient fuel. Like if you look at the number of oxygen molecules required to create energy and so forth, it's just more efficient with ketones. I guess the other part you can say though is how it doesn't require insulin to get into the cells, right? So it's to be used more efficiently. The other part though that's so interesting is separating the effect of ketones versus the effect of a ketogenic diet. Because ketogenic diet, you're reducing your carbohydrates, you're getting rid of the refined carbs, it's a much better diet overall than the standard American diet. So that's automatically going to reduce inflammation. That's automatically going to help you produce fuel more efficiently and burn cleaner. So the ketones and the ketogenic diet, I think, go together. Now we can get into this. People are studying whether you give exogenous ketones and eat whatever you want, whether that has the same effect. No, I mean, I think you got to have the 1-2 approach of the better diet, the keto diet, improving your metabolic health, plus the effect of ketones in the brain. That's how you get to this cleaner fuel supply and this more efficient fuel, improving your metabolic health and having the direct brain impacts of ketones.
Yeah, I 100% agree, because as soon as people start optimizing their diet, I mean, honestly, if people go vegan for a little while, or they go full carnivore, or they go keto, they're going to take out a lot of their processed foods, and they're going to feel better for a period of time. Then the question is, what is metabolically healthy over the long term for that individual? And that's a question, right? I mean, the carnivore diet's not really sustainable for most people. The ketogenic diet is hard, but it's not as hard as people think, I think is what it comes down to. And certainly going vegan is interesting. I can tell you from my personal experience that doesn't work for most people on the client side when I work with people and looking at their labs over time. But I think the point you make is the inflammation goes down because the system is not seeing as much junk. And that's
certainly one reason.
And that's obviously a good thing. And then, of course, you have the clean burning fuel, which is beta oxidation, which is making energy from fat instead of making energy from glucose. Don't we also know that our ability to make energy from glucose gets worse as we get older, I think, as well?
Well, I mean, as we get older, we tend to get more metabolic dysfunction. So I think that's probably got something to do with it. Our mitochondrial health and function decreases. And so, being able to transition to burning fat for fuel is certainly helpful. But I want to, if I can, just go back a second, because you mentioned, vegan diets, carnivore diets. And so here's the thing about ketogenic diet. There's not one ketogenic diet. Ketosis is a state of being. Nutritional ketosis is a physiologic state. You could have a vegan keto diet. You can have a carnivore keto diet. You can have a vegetarian keto diet. You can have a Mediterranean keto diet. It can fit into any dietary pattern. And it's just reducing the carbs low enough that your body switches from burning glucose for fuel to predominantly burning fatty acids for fuel. So it can fit any dietary pattern. And that's one thing I think people need to realize. It's a ketogenic therapy, and you can get there with nutrition, and you can get there with any type of nutrition. But people don't necessarily see it that way. They just, they think it's bacon wrapped steaks cooked in butter, and that's all you eat, which actually can work for a lot of people, especially people that have like immune conditions or whatever. Like there's a subset of people where that type of diet can work well. But that is not a keto diet. It's also, salmon and asparagus and spinach and avocado and nuts, that just fits in beautifully with this Mediterranean pattern, right? Like, so we have to get away from thinking of the keto diet as one thing.
I really appreciate you making that clarification, and I wasn't trying to allude to that, but I really appreciate No, perfectly. I'm so glad you went back and said that, because it's really important to know that. I mean, I know people that are vegan keto and that are doing these other kinds of things because of ethical reasons or other philosophical reasons, and I think that's really great as a point to make it clear that you don't have to fit into one dietary strategy to be ketogenic. And I think that's really important. So thank you for mentioning that, Bret. So going back to the brain and mental health. Now we know from the world of epilepsy that the ketogenic diet is safe. It's effective. It decreases seizure risk. And what other conditions are you looking at or most exciting for you that we're seeing significant benefit? I mean, you spoke about the Baszucki son and bipolar. Yeah. Do we have any other evidence on that side, or are there any new studies that are coming out, or the pilot studies that you guys are doing now that we can talk about that might be cool for us to learn about?
Yeah, your original question was about evidence, and I just went off on a tangent there.
No, it's all good. I do that all the time.
Yeah. Right. So, all right. So now, fast forward to evidence that we have for mental illness, and actually, this was very exciting. We were just at the International Society for Bipolar Disorder conference in Chicago, ISBD in Chicago, and there was a symposium led by Dr. Danny Smith from University of Edinburgh, where there were 3 different research studies presented. One was by Dr. Ian Campbell and his team at Edinburgh, where they studied ketogenic diet intervention for people with bipolar disorder. And it was preliminary data, it's not published yet, but very exciting to see it presented with very significant, impressive improvements from a mental health standpoint, from a metabolic standpoint, with just using the ketogenic therapy. Dr. Shabani Sethi from Stanford likewise presented her pilot study. Again, not published yet, but exciting that it was presented. This was the first presentation of it, showing very similar, safe, effective, and able to do. So a lot of people question, well, people with mental health disorders, are they going to be able to actually stick to a diet? And in her trial, yes, they absolutely were able to stick with it, and they saw dramatic mental health and metabolic benefits. And then the third one is a trial that has been published, or a study that has been published. Dr. Georgia Eade worked with Dr. Albert Denon, who's a psychiatrist in France. And what he did, he'd been following his patients for years and years and years. And he had 31 of his patients who just were not getting better. No matter what he tried, they were not getting better. So he said, okay, what we're going to do, and they've been in and out of the hospital.
This is bipolar as well, correct?
I'm sorry?
This is bipolar disorder as well?
For Dr. Denon, it was bipolar, schizophrenia, and major depression.
Oh, wow, okay, all 3.
And he said, I'm going to put all 31 of you in the hospital, and we're not going to change anything except we're going to feed you a ketogenic diet. And see what happens.
So stayed on the same medications?
Same medications. Okay. Well, one of the results was that like 50% of the patients were able to reduce their medications because their symptoms were getting so much better. Wow. Everybody saw an improvement. There was a number who went into clinical remission, which is, if you talk to most psychiatrists, they would just say, no, clinical remission doesn't happen. We just don't see that. It doesn't work that way. But yes, he saw that. So, so the research is definitely catching up, and we have some pretty impressive results. Now, as we, this is how research starts. You start with the pilot trial, you start with the non-randomized trial, and you work your way up. It has to kind of go through that progression in order to get proper funding and for enough researchers to get interested and involved. But we're really starting to see this take off. So in the next few years, we're just going to see an explosion of more research in this area.
Where's the funding's coming from? The Baszucki family? Or, the problem with this, as you know, is that where is the $1 billion Lipitor at the end of the rainbow here, Bret? There isn't one. What are we going to do? How's this going to continue to get funded? What do you think?
Yeah. So for the trial in Edinburgh and trial at Stanford, which Dr. Sethi, Baszucki Brain Research Fund helped fund those. And now there's one going on in college kids at Ohio State. There's another one going on at University of California, San Francisco. There's another one going on in Australia.
Awesome.
And there's one, Dr. Brietsky's doing one up in Canada. So, they're not all being funded by Baszucki's, but Baszucki Brain Research Fund is funding at least 5 right now, in the process of probably funding a couple more. And what we hope is, though, that this is going to draw the attention of other people, whether it's other donors, other private funders, but also, for government sources of funding to say, look, there's a groundswell here. There's something here we need to pay attention to because this is going to impact the lives of hundreds of thousands, if not more, people for the better and reduce healthcare costs. I mean, if you look at the healthcare costs associated with mental illness, with major depression, the disability costs associated with that. I mean, the government should have some vested interest in making sure we come up with better treatments, and this could be one of them.
Yeah, I really hope that's the case. I unfortunately haven't seen it be the case in many times, in many places, for many things like PTSD or traumatic brain injury and things that I work on a lot in the hyperbaric space. You'd wish that they'd do more work in getting somebody into a hyperbaric chamber, but the evidence is there, but they won't do it, kind of thing. But there's always like levels of politics and playing with research and everything else. So I think that I really hope that we can get there with what you're doing. But one thing about that last trial you mentioned, where the 50% of the patients were able to decrease their medications, was this across the board, like as far as depression, schizophrenia, bipolar, everything, or was it like the bipolar was like by far and away the one, and then everything else was less, or how did it all kind of shake out as far as the different?
That's a really good question. I don't quite remember that breakdown.
Okay.
I'd have to refresh my memory and look back at the paper.
No, that's all good. I mean, in the sense of, do you have a sense just sort of overall, does it seem to help every mental health condition across the board? You even mentioned anorexia earlier, which is really one of the most recalcitrant ones out there as far as mental health conditions go.
Yeah, so when it comes to schizophrenia, schizoaffective disorder, bipolar disorder, and major depression, yes, it appears it has a pretty equal effect on all of those. Now, with sort of moderate depression or mild depression, if you talk to like Dr. Chris Palmer, he says he doesn't see quite the improvement there, and he thinks it's because those diagnoses are a little more heterogeneous. But by the time you get to major depression, then it's a little more consistent, at least probably from a mechanistic physiologic standpoint, as bipolar and schizophrenia, in terms of like sort of the brain energy, the mitochondrial dysfunction, and that's where maybe the ketogenesis can have the most impact there. But same for generalized anxiety disorder and severe anxiety, and potentially things like PTSD and brain injuries might also benefit.
Right.
Research is sort of catching up, but there's definitely clinical experience. But you mentioned anorexia, and this one's really fascinating. Mostly because, fascinating for a number of reasons, but, restrictive diets are absolutely 100% contraindicated. Don't even try it in anorexia, right? But thanks to some brave individuals, Caroline Beckwith, and along with her aunt, Dr. Barbara Skolnick, they tried a ketogenic therapy with her, along with ketamine infusions, and kind of resolved her long-standing run with anorexia. And then from that, they did a 5-person pilot study where, again, they used a ketogenic therapy combined with ketamine infusions and saw dramatic improvements. And then from that, we've learned so many different anecdotal reports and clinical experience of using ketogenic therapies, even without ketamine, just ketogenic therapies, and how that has improved the lives of so many people with anorexia. So now Dr. Guido Frank at UC San Diego is doing a 20-person trial of ketogenic therapies, and they're actually enrolling now. So if anybody's listening and this applies to you or someone you know, reach out to Dr. Guido Frank at University of California, San Diego to see if you want to be in the trial. But the thought is, people with anorexia have such a focus on food and food restriction that all foods are good, and you should eat all foods, and you should just be welcome to eat your ice cream and your cakes and your pies and your white bread and
it's all calories, right? It doesn't
it's all just calories.
Right.
But if you want to just restore weight and look at anorexia as just a weight problem, okay, I guess maybe you could say that's true. But anorexia isn't just a weight problem. Anorexia is also a mental illness that involves your brain and your thought process around food and your need to restrict. So when you look at it from that standpoint and you want to address the voice, as they said in this trial, the voice in the head's quieting the voice of anorexia, that's where ketogenic therapies can be so helpful. And that's what we've seen. Now, doesn't mean everybody with anorexia should run out and try ketosis. You have to make sure you do it in a weight-stable way, right? Because some people can lose weight with nutritional ketosis. So you have to make sure it's a way that doesn't induce weight loss. And for most people, it won't, because it's more of like a weight optimization than a weight loss. Yeah. If you don't have the weight to lose, it's unlikely you're going to. But you should do it with clinical guidance, because then if you can help with the weight and with the brain process, the psychiatric process involved in anorexia, that's where people have seen benefits that they couldn't see anywhere else.
That's amazing. I still work part-time at the hospital, and I see some of the hardest patients to treat are the patients that are underweight anorexics. And that they're going to get better for a short period of time. They're going to come right back, and they'll eventually die. Yeah. Unfortunately, the risk of death in anorexia is just so high, especially if you've had it for a long period of time. So I think you made a really good point here, is that you have to, if it's just a weight issue, it's not just a weight issue, right? Obviously, it's a mental health issue, and that's why they have these these thoughts and these patterns that need to be reprogrammed. And it's super interesting to me that, and I didn't know this until you just mentioned, that these initial people were working with ketamine as a way to help recalibrate the brain and also work with the ketogenic diet at the same time. Is this something you guys are looking at in any context, as far as looking at maybe not just ketamine, but other sort of psychiatric specific, like integrative care outside the conventional box alongside the ketogenic diet?
Yeah, I mean, it's so interesting to think about. The ketamine field is exploding.
Right.
Psychedelic field is exploding, and CBD, and so many different things people are looking at. At Baszucki Group, at Metabolic Mind, we're not looking at that. We're focused on metabolic therapies, but we acknowledge that we're glad that other people are doing this research and looking at it, because look, we want any alternative therapies that are going to work. We're going to focus on the metabolic health, mental health combination, metabolic therapies, ketogenic therapies, but whether or not they can be combined with other alternative therapies, that door is certainly open.
Sure.
I'd like to see other people investigating that.
Yeah, it sounds like the next sort of evolution is that there's ketamine and then, the ketogenic diet, then there's going to be psychedelics in the ketogenic diet.
Yeah.
But of course, a lot of this has to do with the actual psychiatric care itself. I'm sure that that's a significant emphasis in the trials that you guys are doing. Like, people are still getting psychiatric care, they're still getting involved with therapists and that aspect. But the interesting part, I think, for me personally, is how is this going to work in the bigger field of integrative psychiatry that's developing, and how can somebody get trained in the work that you guys are doing and then start using this? I mean, even as a cardiologist, you were having people, work on the ketogenic diet and having ketogenic coaches and things like that. I would imagine do you have a big vision of this? Like, where psychiatry is going to go? Like, do you think that in the conventional world, it's just going to be accepted, and that you're going to have like people that are coaching them on ketogenic diets, or what is how doctors are? We're not that flexible. We're not metabolically flexible. We're not metabolically healthy either, but that's another story. What do you see as like sort of like the path forward? Like, what's your like 5-year, 10-year? Where do you want this to go, or where would you love it to see?
Yeah. Well, first start with where we are now. I mean, we have a YouTube channel that just started, a few months ago, I guess. And, the goal there is to provide people with this information, clinicians included, so they can learn about what this is and how to use it with their patients. And now we want to build out specific clinician education, knowing that, look, we don't expect a psychiatrist to sit down and be like, here's your shopping list, here are the things you can eat and not eat, here are your recipes. No. But we need a psychiatrist to know enough about it, and to have connections to be like, here's a nutritionist or dietitian you can go talk to, or here's a mental health coach you can talk to who knows about ketosis. I'll follow you for your medication therapy, and we can adjust if needed, but they'll help you with the ketogenic diet, and you the psychiatrist can introduce it. That's the point we want to get to, that the psychiatrist knows about it, knows it's a safe and effective therapy, and knows how to build a system to help it work. So Dr. Georgia Eid at diagnosisdiet.com has a directory of people who've gone through her training course, and people who've sort of self-identified as familiar in this area. So if someone's looking for a clinician to work with, that's probably the best place to start right now. We hope to build out more clinician training, both, again, from a dietitian standpoint, from a doctor standpoint, from a health coach standpoint, from a mental health counselor standpoint, from a psychologist standpoint. All these people who are involved in the care of people with serious mental illness, we want to know about this.
Right. They want them to have an access point to it. I would recommend CME credit. That's always the easiest way for doctors.
So Dr. Eid's course has CME credits available.
That's awesome. Yeah, that's awesome.
And we're looking to build out more CME activities. Because look, I mean, doctors need to get their CME, and where are they getting a lot of it now? From the drug companies, unfortunately, because they have the money to support it and do the advertising, and that's not where I want to get my CME credits. That's not where I want my doctors to get their CME credits. We definitely want to provide that. Yeah,
one of the things I've heard you talk about a little bit as I was doing some research for our podcast is the levels of evidence. You've talked about this a little bit, and I think it's important because I want to transition a little bit to a number of questions, but certainly what comes up in the level of evidence is that let's talk about how we make our recommendations. Overall, you can stick to the cardiology side if that's where you feel most comfortable. You can stay on the mental health side too. But there's all these various levels of evidence that we use, and how does that work as far as what we get trained as medical doctors to actually understand. What's the paradox there?
Yeah, I think a big problem is medical doctors we're frequently not trained about being able to critically evaluate the level of evidence. It's so common to just say, oh, the research shows or evidence shows. Like, well, whoa, hang on. What are we talking about? What level of evidence? Because especially when it comes to nutrition, when it comes to, nutrition in health and medicine, the majority of the studies are these just large observational studies where we don't do any sort of intervention. We just follow how people live their lives. Well, that is the lowest level of evidence, or one of the lowest level of evidences, and the inputs are so poor because they fill out a questionnaire maybe once for the entire study, or once every 5 years, or once every 10 years about how they're eating. Food, a lot changes in that time, and you're only capturing it every 5, 10 years, or maybe even once. That's really poor input. The second point is, though, you cannot account for all, you cannot account for all the other healthy or unhealthy activities. And that's a huge problem, because when you look at, just take saturated fat or red meat as an example, when you look at those, big 100,000 person studies looking at people who ate more or less red meat, well, what you also see is the people who ate more red meat drank more alcohol, exercised less, they ate more carbs, they ate more calories, they took less good care of themselves. And you can try and statistically account for some of those, but there's no way you can just account for how someone lives their life and how healthy they are. How do they sleep? How angry do they get? How do they manage their stress? Right? Like, what else do they do? You can't account for all of that.
Their gut microbiota.
Right. And then you fast forward to the results of these studies, and you get a hazard ratio of 1.2, meaning they're 20% more likely to have a cardiac event, which sounds kind of scary. But to put it into perspective, when you look at smoking and cancer, there the hazard ratios were like 15 to 30, not 1.30, but 15 to 30. And here you're talking about 1.2. It is such a razor thin, minuscule difference that when you factor in all the low quality inputs, to then translate to what that means for me talking to you as my patient, as an individual, what impact will it have on you? It's like none. But yet this is the evidence we use to say red meat causes cancer, red meat causes heart disease, the healthy diet avoids red meat. That's the level of evidence we have, which is like mind-blowing that we could get from point A to point B.
And what kind of red meat, right? They're using, how do they define red meat? It's like McDonald's hamburgers is red meat. It's not grass-fed steak from your local butcher at all. I mean, that's absolutely. The other aspect of and I completely agree with you. Like the amount of evidence, the amount of the hazard ratio is so small, and then the evidence is so poor. But please continue. I don't mean to cut you off. I think it's a really good point you've been making.
Yeah, that's well summed up. And so when I give my talk, I show 2 slides, and one is like this beautiful looking salad with some strips of beef on it. And then the other is a huge sandwich with a bun this big with a little bit of meat and cheese in it.
Like Katz's Deli from New York City or something. Like you're like your 1 pound of beef on a type of on a sandwich.
Well, or even worse, like Subway, where your meat is this big.
Oh yeah.
Your bread is this big. Right?
Exactly. Yeah.
Or a big plate of spaghetti with some meat sauce on it. In a study, all 3 of those are red meat, right? But your body's going to see them very differently. And so if that's the quality of evidence we're using to make individual recommendations and blanket recommendations that red meat's bad for you, I mean, that just shows you why there's so much confusion. Because there should be confusion, because that quality of evidence is just not right for that type of recommendation.
And for saturated fat, it's very similar, correct?
Yeah, for saturated fat, exactly, very similar. And is saturated fat from red meat, or is it from a pie crust, right? Those are 2 very different forms of saturated fat that you're getting there, and your body's going to see very differently. And same sort of thing. Yeah. So, and it doesn't mean, okay, so then you could say, well, I throw my arms up in the air, we just have to ignore all nutrition research. Well, I mean, that's hard to do too. You don't want to just ignore the research that's out there. So it is a balancing act to try and put things into perspective. And, randomized controlled trials for nutrition are short. They're 6 months, they're a year, right? Because it's really hard to do dietary randomized controlled trials. So if you're looking at a disease process that takes 10 or 15 years to manifest, those aren't, high quality either. All right, so then you have to fall back to surrogate markers. where the main surrogate marker people look at for heart disease is LDL. But is LDL all that there is for heart disease? No, absolutely not. And there's actually one study that came out looking at, I think it was the Women's Health Initiative over time, and they looked at what markers at baseline best predicted progression to heart disease, 15 years down the road or so. And I made up 15 years. It was some point, but I forget the exact year. And LDL was on there with like a 1.4, I think it was, increased risk. ApoB was better at 1.8. But then there was type 2 diabetes at 10. There was insulin resistance score at 6. And, here's LDL and ApoB down at like 1.4, 1.8 range. So it's not that it's zero, it's on the list, but maybe we should think a little bit more about where it fits in the overall makeup of cardiovascular risk, right? So when we focus on surrogate markers, now we have to say, okay, what surrogate markers, and is it the right surrogate markers? So these are layers of the onion that people don't have the interest or the time to peel off when looking at all this research, which is what makes it so confusing, unfortunately.
Yeah, I mean, as we both know, how much time does a doctor actually have to spend with their patients in the conventional model? I mean, it's about 15 minutes. I think less than that. If you think about how much time they're actually speaking to the doctor, as opposed to how much time they're actually trying to document the experience or document the time that they spent with the patients, basically. So we have to figure out ways that we can get this information to doctors and practitioners, but fitting in that model is very, very hard. When you have to have a very nuanced conversation about your risk, especially from a cardiology risk. I know you have your own practice and you do this you have your own concierge telemedicine practice. When you think about these risks, you think about ApoB, you think about LDL, you think about inflammatory markers, you think about calcium scores, you think about other types of things that are available. How do you put this together for people? Do you have a pretty easy way of saying, like, this is how I think, this is my overview? I'm sure you have to do this when people are kind of coming into your practice and they say, all I care about is my LDL. I wanted to make it 4. Like when I was born, I think, what is your LDL, like 40 when you're born? I think like that, right? Or something like that. Yes. I want it to be 4. I'm like, and my question is like, is that really a good thing? I mean, I know from an evolutionary perspective, and I think about this a lot. I really appreciate you brought that up in the beginning. From an evolutionary perspective, we're just overfed and we're producing too much energy and our body's trying to do something about it. And then that's creating all this inflammation. And the same can go with lipid panels as well, with your cardiovascular profiles and how our body needed to hold on to various things when we had famines, right? And we didn't have the ability to carry our proteins and carry our triglycerides, et cetera, because we didn't have enough LDL particles around and things like that. I know it's kind of a long preamble, but these are just some of the ideas that I think about when I'm talking to patients about their cardiovascular risk. How do you kind of put that together for people overall?
Yeah, I mean, I guess the biggest benefit of my practice and being a small practice is I really can individualize things and work with people on a one-to-one basis, which is how medicine should be. But like you said, when you have 10 minutes with somebody, it's so much easier just to go by the guidelines, treat everybody the same rather than individualize it. So look, I mean, there are some people who I want their ApoB really low, right? For people who have developed heart disease while having good metabolic health and with a strong family history of heart disease. And like, okay, we've optimized your inflammatory markers, we've optimized your metabolic health, your blood pressure, your blood sugar, your insulin. We've done all these things and you're still showing progression and your ApoB is elevated. Okay, that's the one thing left we can really address. Let's lower your ApoB, right? So I have no problem recommending a very low ApoB or LDL in those settings. But somebody who is developing heart disease with metabolic dysfunction and high blood pressure, I'm going to almost always attack that first with that individual. Let's see what happens with your LDL and ApoB. Let's then decide how to approach that. It's a more individualized thing, but also, like you mentioned a calcium score. We don't have to just go by what your lab tests show. We can look at your arteries with a calcium score, even better, a coronary CT angiogram, which is more expensive, harder to get, little more radiation, not a ton more radiation nowadays, but a much better test if you can get it. So again, my luxury is I can work with people individually and we can get CT angiograms. I can look at the CT angiogram with them. 20 years ago when I started doing CT angiograms, they were 15 or 20 millisieverts, which is a measurement of radiation, whereas a calcium score is 1 millisievert for comparison. Now we can do CT angiograms for 2, 3, 4 millisieverts. So it's much more accessible from a radiation standpoint. Right. 0, of course, but lower. So I like definitely. That. So you can see what's going on in the artery rather than guessing.
Are there any other imaging studies that you're using for people to kind of assess cardiovascular risk other than CT angio or calcium scores?
Yeah, so carotid intima media thickness, CIMT, is another good one. It's an ultrasound of the artery, but not your just, show up to any radiology department and get an ultrasound that looks for plaque. This is a specialized one measuring the wall of the artery. If you look at studies comparing prognostic value of, one CIMT versus one calcium score, the calcium score is better. It's got more data behind it. It's more predictive. But the benefit of the CIMT is that it's going to change more quickly. It can progress and regress, and has 0 radiation involved. So if you want to follow it every 4 months, every 6 months, or whatever, it's a test that you can use more frequently. And I think the delta is really helpful for CIMT. So that's one I like to use as well.
Nice. So you can actually see the progression faster or the regression faster using the carotid as opposed to the calcium score.
Exactly.
How often can you repeat? I mean, you don't want to repeat the calcium score, so the coronary angiogram very often because of the radiation. But how often would you typically do that in somebody that you were following in that way? Would it be yearly, every couple of years, or how do you typically do it?
Depends. Again, depends.
Yeah,
Depends.
I love that answer. I say that all the time. I say depends. It depends. Yeah. Don't ask me to don't nail me down.
But like one. I can think of one patient I've had recently where we got a CT angiogram, and he had some soft plaque, and so we did start medical therapy in addition to lifestyle therapy, and we repeated it in a year to see what happened with that soft plaque. Now, in that situation, if it's stable or improved, I'm not going to do it every single year, right? I'll probably space it out 3 or 5 years or whatever, because it's a more invasive test, and although still non-invasive, but more expensive and high radiation. If it continued to progress, maybe then I would do it. We would change something else. Maybe then do it again in a year. But that's being pretty aggressive. But in the right circumstance, it's the right thing to do. So, when we're trained as physicians using radiation, and I was, certified in CT angiogram and certified in nuclear medicine, so I had to go through all these trainings. This one concept was ALARA, as low as reasonably acceptable. So we don't set a limit, like you're only allowed 10 millisieverts for the year or 5 millisieverts. You don't set a limit. You have to operate under the premise of you want to keep radiation as low as reasonably acceptable. And it comes down to, would this test impact your care? Would getting this radiation impact what we're going to do with your care in some way that we can make your care better and make you healthier? If the answer is yes, then chances are that low dose of radiation is worth it. Right.
That's a great way to say it. Although, if you go to any emergency room right now, you would likely get a CAT scan. So.
Right.
Believe me, it's kind of funny actually. If you have a pain anywhere, you're going to get a CT of it. But that's beside the point. I think given I have you, and I do have interest in this topic myself, is when you talk about having to lower people's ApoB or lowering their LDL because they have risk factors, you've done everything else. Like you're not just, unless it's an emergency, you're not going directly to medications and things. What is your sort of like your process there? Because obviously there's a lot of people that love statins. There's a lot of people that hate statins. There's a lot of people that are interested in the PCSK9s and these other kinds of things that are coming in. Do you immediately go to statins? Do you skip that step and go to PCSK9s? What is, and this of course is going to be very individualized. I understand that. But I think overall the question is, how do you feel about statin medications as a way to lower some of these markers in people that are at high risk given everything that you've said?
So I want to get into that, but it's a minefield. So before we get into the minefield, let's talk about ApoB and LDL in general, and tie it back to how we started on ketogenic therapies for mental illness. So as a clinician, or even as an individual, a lot of people work under the assumption that, ketogenic therapy may help this, but it's going to raise your LDL and increase your heart disease risk. So no, let's not try it. When actually that's not true. The overwhelming majority of data show that when you start a ketogenic diet, your LDL does not go up on average. There are obviously some people where it does, but on average it doesn't. So because of this focus on LDL, so many doctors assume ketogenic diet equals high LDL, therefore you should not try it. As opposed to, well, since it could have these potential benefits, and most people don't get a high LDL, let's try it and measure your LDL and see what happens. If LDL goes up, I still wouldn't say it's an automatic, no for the diet. Then you put it in the overall perspective, the risk-benefit ratio, because see what benefits you're getting, see what the risk is, and then you can address whether or not to lower the LDL or ApoB or follow it, or, there are lots of different approaches. So that's the first concept, is getting over that assumption.
And different types of LDL sizes too, right? LDL is just not one thing. That's important to mention too.
Right. So as your metabolic health improves, certainly with nutritional ketosis, ketogenic therapies, where your metabolic health is going to improve, you're likely to increase your larger LDL particles, not your small LDL particles. You're going to lower your triglycerides. You're going to raise your HDL. You're going to lower your insulin. When you can factor all this into a more comprehensive cardiovascular risk assessment, rather than just looking at the number of LDL, and even worse, just the LDL cholesterol rather than the LDL particles or the ApoB, or looking at remnants as well. Like, all those things add to the cardiovascular risk assessment. So the first thing is, when using ketogenic therapies, is, for mental illness or for seizures or for type 2 diabetes, it's not an automatic assumption that LDL goes up. Okay, but then to get back to your question, how do I approach lowering ApoB for those people who we feel it is the right approach for? And again, it's very individualized. There are dietary approaches. So if you don't have to be in nutritional ketosis all the time, you can cycle in and out of it. You can use carb cycling, or you could stick with a moderate low carb diet instead of a very low carb ketogenic diet. And that will almost always affect LDL and bring it down. You could swap out saturated fat sources for monounsaturated sources. That will sometimes help lower ApoB and LDL. So those are some dietary approaches. But if you are someone who you're using ketogenic therapy for a targeted treatment and you want to stay in ketosis, and it's just much more enjoyable and logistically easier and sustainable to do it with saturated fat sources, and you still want to lower LDL, okay, you could talk about supplements like berberine or red yeast rice, which have some effects. I will use them in some circumstances, but not all that frequently. And then the medications, statins, Zetia, PCSK9 inhibitors. There's a couple new ones on the market that I think are going to be less, just used less frequently. But so again, very individualized, depends on the person. I happen to like statins for people with established heart disease because there is evidence of plaque stabilization, which is really important. Right. Because it's not even how much plaque, it's not even if it's 90% narrowed or 40% narrowed. It's how unstable is that plaque, and can it rupture and block the entire artery? That's the number one thing you want to prevent. So if statins can have some plaque stabilization effect, I want to get that effect.
Makes sense.
But in terms of lowering ApoB, I'm a big fan of ezetimibe or Zetia. And in the general world, the general studies, the high carb eaters, metabolic dysfunction, Zetia lowers LDL by about 15% or so. So cardiologists don't get very excited about it. But in my practice, where I focus mostly on people eating low carb, I see 40-50% reductions with Zetia. So
of their ApoB or their LDL?
Of their LDL, and usually like 30, 40 on ApoB as well.
Wow, and it's usually pretty well tolerated as far as...
And it's very well tolerated, right? Yeah, exactly.
As opposed to the statins, which can have a significant sort of spectrum of tolerance depending on the patient and the person.
Right, right.
There's a lot of people that say that we talk too much about statin side effects, and that's why there's too many side effects. I don't necessarily fall into that category. I think that there are lots of side effects. I mean, we know what it's doing. We know it's where it's blocking steroid synthesis and in the adrenal glands and everything else. So I think that, as you said, everything has to be individualized. But I didn't know that about Zetia. That's very interesting. So that it has a significant effect on, like in your patients, especially because you're also following a metabolic therapy, that you have a significant decrease in LDL as well as ApoB just with Zetia itself.
Yeah. Yeah, unpublished data, obviously, just from my own clinical experience.
That's your clinical experience.
Yeah,
that's super helpful just for me personally to know, as I'm getting older now and understanding like these are things that I have to think about as well, and not only for my clients and for my patients. And the way I work typically is I work very much as a concierge consultant, where I do lots of metabolic testing, I do gut testing, neurotransmitters, and then I do hormone testing, and I sort of optimize from the ground up. And as you were saying, like when you do this, when you change your diet, you optimize all that stuff. like most of these markers are going to improve, on their own, in quotes, right? In the sense that, like, oh, their LDL is better, but we didn't touch the LDL. We just changed their diet, or we just made sure they got better sleep, or, the various types of things. But one thing you mentioned that I would like to talk about as a good transition point for just as we kind of wind down the conversation, is you talked about cycling. This is one thing that happens a lot. One question that I get a lot from people in this world, in metabolic therapy world, that are interested is like, well, do I have to stay in ketosis all the time? And there's probably certain people that do, and we can talk about those people. Maybe it's on the mental health side, maybe it's on the cancer side, for example. The people that I see are on that side. And then what is the benefit of being metabolically flexible in the sense that we have a significant, we know that if you are ketogenic and you have like very little carbs, if you have a high carb meal, your glucose is going to go pretty damn high. but that's not necessarily a problem, right? And so let's talk a little bit about what that means overall.
Yeah, another big topic. But I like how you set it up with, do you need to be in ketosis or not? And if you're using ketogenic therapies to treat cancer, to treat bipolar disorder, to treat a specific serious condition, then chances are you do want to remain in ketosis. If you're using a ketogenic diet to improve your metabolic health or to lose weight, maybe you do not need to be in ketosis continually. And in the beginning, you probably do, though, because there is this transition that happens to this, term of metabolic flexibility. So someone with type 2 diabetes who has a lot of visceral fat and high blood pressure, chances are they're not going to be very metabolically flexible, at least not for 3 months, 6 months, 12 months, something like that.
Right.
But once you get to that point where your metabolism is much better, your metabolic health is much better, you put your type 2 diabetes in remission, you've gotten rid of most of your visceral fat, then you may be at the point where you're more metabolically flexible and can go to, a couple weeks of ketosis, a couple weeks off of ketosis. You can go to 50 grams of carbs instead of 25 grams of carbs. You might be able to make that transition, monitoring, of course, how you're doing. And that can be beneficial for a number of reasons. One, it's more flexible, which some people can enjoy. Is there a health benefit to that? That we don't know. That's purely speculative. I've heard people say, we get comments on our YouTube page all the time. Well, it's dangerous to be in ketosis all the time, so you should cycle in it. Where's the data for that? There's absolutely no data to suggest that. There's no data the other way either, to say it's, 50 years of continuous ketosis is healthier than cycling. Who's got that data? So we can't make, definitive statements about that. But some people feel better cycling, and that's okay, and they can do that. But once they're at the point where they're metabolically flexible, certainly not when they're starting out, and certainly not if they're using ketogenic therapies to treat a certain condition. Now, there are some people who treat bipolar disorder, maybe a couple that I know of, who treat their bipolar disorder Monday through Friday with a ketogenic diet, and weekends a more liberal diet, and then Monday through Friday on a ketogenic diet. And they say that works well for them, but one of them has experimented with going 3 days a week on a keto diet, 4 days a week on a more liberal diet, and he's like, my symptoms come back, I cannot do it. But if I do 5 and 2, I can do it. But I would never recommend that. But if someone experimented with that under clinical guidance and under careful conditions at the right time, and it works for them, fine. So there's a lot we're learning, obviously, but there's this concept of metabolic flexibility, and these individuals are very metabolically healthy, so they can switch back and forth very easily. Whereas if you're not, it's a lot harder to switch back and forth from a glucose burner to a fat burner.
I love that point, is that if you're metabolically healthy, it's probably okay to be flexible. But if you're not metabolically healthy, it's probably not going to work. So it's not going to work as easily. I love also the other point that, like, as you go and you work with people, or you're doing this on yourself, of course, hopefully with medical supervision, is that you can see there's nuances here. Like, you can do 5 days a week, 2 days off, and that works for your bipolar, fantastic, right? But that's not something you can say across the board. But I think overall what you can say across the board is that if you're metabolically flexible, you have the ability to potentially switch back, or you're metabolically healthy, you're more apt to be more metabolically flexible. And I think that's a really great point, because you have people like that. My patients will say, oh, I heard about this metabolic flexibility thing. In some terms, they won't use that term, but they'll say, well, can I just do keto for a couple of weeks and then go back to regular and then go back to this? I'm like, no, you can't, because we're doing it for this reason. And then, of course, if there's more specific reasons like cancer or mental health, then that's a different story altogether. But yeah, I think it's a really great point, Bret. Thank you for mentioning it. So I don't want to take up too much of your time, more of your time. I've already taken up enough. And I appreciate you sticking around. And really, this has been really helpful. Really helpful for me to understand and to learn. I know listeners will be as well. So one more question. And I didn't prompt you, but I know you're going to have good answers to this anyway. So what we ask all of our guests at the end is, our podcast is called the Smarter Not Harder podcast, right? And so the question I have, and this could be in the realms of the work that you do, in the realms of life, is, what are 3 ways that all of us can live smarter, not harder? And like I said, it could be something from the world of cardiology, it could be the world of metabolic mind, it could be, working with your kids, and it could be anything you want. But what are 3 things that you think we all can do relatively easily to live smarter, not harder?
Sleep, eat, and move your body. Sleep, eat, and move your body. So really prioritize sleep. Don't just, put it off as like the last thing, but think of it as a treatment, as a consistent treatment for your mental health, for your energy, for your productivity, and for your metabolic health. Try and go to bed at the same time, wake up at the same time every day if you can. Try and prioritize your sleep. Eat. You got to pay attention to what we eat. The food we eat is either helping our health or harming our health. So does everybody have to be ketogenic? Absolutely not. Should everybody be some version of low carb? Probably. Should everybody be closer to a whole foods diet? Absolutely. So really focusing on the inputs that we put into our system, and move your body. I mean, if we talk about, evolution, where we were active all day long, and now fast forward to now where maybe we do 30 minutes on the treadmill and then we sit the rest of the day. No, that's not a healthy way to move your body. Actively look for ways to increase movements in your body. And then last thing is, find joy. That's I think you asked for 3, so that's 4.
That's a bonus 4. I like the bonus 4. That's lovely. I like it. Yeah.
Find joy. Like for me right now, there's nothing more important to me than getting outside and throwing a baseball with my kids. If I can do that, that brings me so much joy and improves my life in so many different ways. So that's a definite thing to include.
I love the bonus 4. Thank you. Yeah, Dr. Ted, who's one of my colleagues and one of the other interviewers, he has a good way of thinking about, your day starts when you go to sleep, not when you wake up.
Yeah.
So it's a nice way to remind people that sleep is absolutely essential. When you and I were in medical school and residency, it was not the case. And people have this idea that sleep is the last thing you need to do, not the first thing, right? So if you remind people, it's like your day starts when you go to bed, not when you wake up. It's also a helpful reframe for that. But in medical school, my classmates had shirts made that said "Sleep is for quitters," right? So that's not the idea. So you can get away with it for a while, but eventually it will catch up to you. And then, like I said, it's sort of like it's a tumbling down the hill as a result of not sleeping after many, many years, as happens to a lot of us in the medical field. So, and then joy is, I'm with you on all of them, but joy especially. I have my 4 kids at home, and I know I have the golden age of parenting as you do, where the kids are young enough that they still want to hang out with me. Maybe your 13-year-old's not quite there anymore. My 12-year-old's kind of not liking me as much as she was about 6 months ago, I'll say. But yeah, joy is a beautiful one. Well, Bret, thanks so much. I think the last thing is just to ask where people can find more information about you, about Metabolic Mind, how they can learn more about your organizations and what you're up to.
Yeah, thanks. I appreciate that opportunity. So Metabolic Mind on YouTube is probably the best place to go, where we have most of our content. Our website's at metabolicmind.org. Twitter, we're metabolic_mind. But YouTube is where most of our stuff is right now. And then for me as a practitioner, lowcarbcardiologist.com. So those are the best spots.
Okay. Bret, thanks so much. I really appreciate your time, and hope we get to meet in person sometime soon. That would be awesome.
Yeah, thank you, Scott. It's been a pleasure.
Okay, take care.
This has been another episode of the Smarter Not Harder podcast. We hope you enjoyed the show. If you did, head over to Apple Podcasts, Spotify, or wherever you listen and leave us a 5-star review. We would really appreciate it. While you're at it, please also go to YouTube and click subscribe. Dr. Bret Scher is a wealth of information. He's a fantastic speaker and communicator when it comes to the ketogenic diet, and his work on mental health, the metabolic mind, organization, the nonprofit organization, is doing some amazing things. Go check that out, metabolicmind.org. And thanks again for tuning into the Smarter Not Harder podcast, your home for 1 cent solutions to $64,000 questions. We'll see you next time.